Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome to this week's episode of the Healing Pain Podcast. I am your host, Dr. Joe Tatta. On this week's episode of the Healing Pain Podcast, we're discussing the influence of social factors on pain recovery. My guest this week is Dr. Kenneth Craig. Dr. Craig is Professor Emeritus of Psychology at the University of British Columbia in Vancouver, Canada. His research focuses on pain assessment using nonverbal methods in populations with communication limitations, as well as the importance of psychosocial factors in understanding pain and managing pain. Dr. Craig has been editor-in-chief of Pain Research and Management, the Canadian Journal of Behavioral Science, and has served as president of the Canadian Pain Society, as well as been an active member in the International Association for the Study of Pain. On today's episode, we discuss why social factors are important, when they come into play, how they are related to the lived experience of pain, and how they affect the care of marginalized populations. Okay, let's begin and let's learn about the social influences of pain with Dr. Kenneth Craig. Hi there, Ken. Welcome.
Great to be here, Joe. Good morning.
Thanks for joining me. It's a pleasure to speak with you today. I was kind of looking over the great paper that you wrote. We're going to link to that in the show notes. Everyone can read it on pain and marginalized groups. And as I was thinking kind of back through our evolution on this podcast, talking about biological factors and social factors, we've covered that quite a lot, quite in depth. And people are now aware of kind of the biocycle and then the social aspect. We haven't covered the social aspect as deeply. Why are the social factors important when we talk about the pain experience?
Well, an interesting question. People certainly endorse the biopsychosocial model, but most of the emphasis goes on the intrapersonal phenomena of the biology of pain and the psychology of pain. Certainly the biology is of paramount importance. We need to know the nature of the injury or the disease or the source of the pain, and biological interventions are first line and have to be used as effectively as possible. But, probably less than 50% of people suffering from chronic pain have a solid biological explanation in tissue damage or disease to account for their discomfort. Similarly, there are huge individual differences in people suffering from acute pain, ranging from people who are quite stoical and handle it with stoicism, through to people who are highly reactive and suffer considerably. So a lot of that variance can be explained through focusing upon psychological factors and social factors. But indeed, the psychological factors are probably best explained in terms of the social processes, because what we think about, how we think about things, the thoughts and contents of our observations usually have their origins in interactions with other people and what we're exposed to.
Mm-hmm. Right. So the thoughts or cognitions that we have in our head or in our mind, we see them as kind of our own. But really what you're saying is there are outside forces that are influencing how we think and feel and behave, if you will.
Sure. Yeah. Maybe the best evidence for that is that if the person comes from a family in which there's unduly vigorous preoccupation with pain and pain avoidance, the child is somewhat predisposed towards that pattern of thinking themselves. And likewise, parents, other siblings, people in the nuclear family will model coping, adaptive reactions.
Mm. So we're talking. So you mentioned obviously the person with pain, and then you kind of took it maybe one step from there. You took it to the family structure. So maybe your immediate spouse or your children, or maybe your parents if you're a child or an adolescent. So that's more of a social kind of in a social
Oh,
container.
absolutely. Yeah, that's sort of been my focus. And
Mhm.
as I say, the biological and the psychological are exceedingly important, but the social has been relatively neglected, and so that has been what I've attempted to focus on. Um, these patterns of emotional reactivity and thinking depend upon biological structures. The evolution responsible for the brains we have and the kinds of things that we attend to. That's very important. But then we get exposed to the immediate environment early in childhood, and so throughout childhood and into adulthood, those historical events, the life history of the individual are important, as is the immediate social context. And so my clinical work, I'd always focus upon those domains.
Mm. And how far does the social extend out kind of from that circle, if you will? Because obviously besides family, there are things like friends and work and other aspects of society that could influence one's perception of what's happening to them.
Yeah. Well, there's been a long history of characterizing societies or countries, regions of the world in terms of their reactivity to pain. I don't know that my gross generalization has broad applicability. I think it does. We tend to think of people living in the Mediterranean cultures as more reactive and vigorous and pain avoidant than the more stoical people in the northern parts of the northern
Mm-hmm.
hemisphere. Very broad generalization of huge individual differences in each of those communities, but the mean differences are likely to stand up.
Yeah. So the broader culture can have an impact on one's pain experience.
Yeah, absolutely. It's just how pain is modeled by other people, and people in the family are part of the community and the ethnic group and the society at large, and so it drifts along in that manner.
So
Mhm.
pain exposure is oftentimes a part of pain treatment. So whether it's, graded activity or graded exposure, there's a lot of different ways. In vivo exposure, a lot of different ways that healthcare providers use exposure to pain as a method of treatment. We talked about it probably a little bit here. We're dancing around a little bit, but how do those social factors influence the exposure to pain?
Well, I have a model of pain in which I like to look at the temporal sequence, beginning with exposure to pain and the social factors that contribute to that, moving into pain experience and the thoughts and feelings, the subjective experience, and then the expression of pain, how the social factors would influence that. And of course, then there's the social world that we interact with, our family, our friends, the community, health service providers, and the like. At the level of exposure, and environments are of variable risk. If you work in an occupation where the risk of injury is substantial, if you're, say, a professional football player or a blue collar worker in an industry that requires a lot of heavy labor and manipulation of tools, then your vulnerability is increased. And so it behooves us to focus upon minimizing risks for people in those environments. occupational health and safety experts are very much focused upon safety. I suspect, I was mentioning professional football players a moment ago. I suspect there's increasing interest in minimizing risk of exposure to serious injury, painful injury.
Good topic, since yesterday was our in the United States, we had our Super Bowl yesterday. So we're talking about footballers, we're talking about maybe soccer players and American football players who both have somewhat risk to them with regard to injury and the
Up
impact
here in
on
Canada, we're talking about hockey players.
right, the impact on the brain and the nervous system.
Big guys skating at full speed or running at full speed, and the objective is to smash into the other person. So you got a 350-pound person operating at full tilt, smashing into you. The risk of painful injury is considerable. And in these sports, I doubt that there's much attention given to documenting the long-term consequences of having participated. But I'd wager that these players in the Super Bowl are vulnerable to painful injuries, certainly as they grow older. Conceivably even longevity could be influenced.
Yeah, because there's certainly traumas that they're experiencing throughout the history of their life, and it's going to have an impact on obviously how their body responds. Yeah. So as I listened to you speak, so you mentioned early life experiences may shape how someone experiences pain. Yeah. You mentioned how the family unit may inform how someone experiences pain. Right. You kind of mentioned like the broader culture, so to speak, may have an influence on what someone's experience of pain is. So when I think of the pain experience, it's kind of, for the most part, it's what is happening inside. You don't necessarily see that happening, so to speak. You can see certain pain behaviors, but you don't really know what's going on inside unless you query or ask someone about it.
Right.
How does the culture or society at large have an influence on one's expression of pain? So now that I have pain and I either want to share it with someone or communicate it with someone, how does the culture influence that?
Well, in infants and very young children, we know that they're in pain because they are expressive. And I think crying, facial grimaces, bodily reactions have a strong basis in evolution, in the sense that these reactions allow other people to know that the baby is in distress and that intervention might be warranted. So these are automatic, reflexive, not necessarily modulated by cognitive higher order cortical mechanisms, that kind of thing. I'm going to forget your question, Joe. But as children grow older, they become more sociable, more social, and learn to communicate in a manner that's consistent with family and societal expectations. And so some level of reactivity is appropriate because it allows parents and others to intervene on the child's behalf. But excessive reactions or no reactions whatsoever have the potential to lead to more serious kinds of problems. Children who don't let others know that they're in pain, people who suffer from what's known as congenital insensitivity to pain, are vulnerable to painful injuries and diseases that can reduce their longevity. These people just don't seem to live as long because they don't enjoy the benefits of pain that warns about disease and injury processes that should be dealt with. So
it is interesting to think about. So in babies and young children, they're more reactive to pain
Right.
from a more almost like an evolutionary perspective, evolutionary response to it.
Absolutely.
And then as we mature, as we age, as I guess we go through the developmental phases,
Right.
our reactions may be what you term more appropriate, so to speak, or more culturally acceptable. Is that the same? Is that the
Oh, yes.
same thing?
Sure. We are finely in tune to our social environment. You and I are working hard to be appropriate in terms of how we define the interview that we're going through at this stage of the game. And the same is true for
Right.
pain and pain communications. So they get shaped by the society that we live in. No question of that.
Yeah, it's interesting to think about because I think sometimes depending on where you work in pain management or pain care, in some places it's acceptable to allow patients to express their emotions about pain, and that may include obviously crying and being very upset. And I think there's other places and maybe with other certain types of health professionals where that's not really encouraged, and sometimes they even see that as the patient being in distress, so to speak, like just crying might equal distress to some clinicians, but that's not necessarily the case.
Right. I think most of us are alerted to the extreme reactions, and those that are most distressing to other people are the high levels of reactivity, and they truly get the most attention in the literature, in part because people whose painful reactions are tempered become suspicious of people who are particularly vigorous in their reactions. And so issues of validity and credibility of the pain behavior the other person mount. So certainly as a psychologist working in pain clinics, I found that my medical colleagues and the other health professionals there turned to me to provide some kind of a judgment concerning the legitimacy of the individual's complaints.
Yeah.
So in my research, we spent a lot of time um, looking at self-report and nonverbal behavior. Um, Self-report, as you said a moment ago, is the primary vehicle whereby we assess subjective experience. My thoughts have gone to the importance of nonverbal expression.
Mhm.
So I think you downplayed a moment ago the importance of nonverbal expression in human communication, but both you and I are paying a great deal of attention to the facial expressions and the head nodding and that kind of thing
Yeah.
of the other person. We do that all the time. And my generalization for that is that we use that nonverbal information to assess the credibility of the self-report.
Mm.
So uh, I tend to think of self-report as more readily manipulated in terms of self-interest. I think nonverbal expression is not quite so readily manipulated and probably is trusted by other people more substantially. I know there's a research evidence base for that particular claim. So both self-report and nonverbal communication play very important roles in everyday communication and in the pain clinic where we're interested in assessing the nature and severity of an individual's pain. I guess I should also talk a little bit more about subjective experience in the sense that there's so much emphasis on pain sensation, and I like to talk about the complexity of the subjective experience and point out that thoughts and feelings are major components of personal experience, as well as the sensory input. I don't want to downplay the importance of the sensory input, but one can amplify or modulate, diminish the importance of the sensory input through emotional reactions and through particular thoughts and feelings. which definitely moves us in the direction of therapeutic interventions, because you can design therapeutic interventions specifically for sensory processes, the emotional reaction of the individual, and their thoughts.
Mhm. All three really important areas that
Indeed.
probably need to be addressed for someone to
Yeah.
reach the level of recovery that they want to reach.
Yeah, absolutely. I mean, I think that the potent medical interventions are oriented towards pain sensation, and so analgesic medications. But then you could turn to the emotional reactions of the individual, most often anxiety and fear, but anger, depression, those can be modulated through pharmacological interventions, and we know the pharmacopoeia there. But they're also they also can be addressed through psychosocial interventions, and really the psychosocial interventions teach people skills, and those skills remain with the individual even though, say, the medication is no longer available to them. So there are specific interventions, evidence-based, developed for anxiety and depression at this stage of the game.
Yeah, there are benefits to having skills. Where
Yes.
if you leave your medicine at home, you don't have the medicine, but the skills always stay with you.
Yeah.
Yeah. How does this kind of the whole social topic that we're talking about? How does this tie in, or how does it start to intersect with marginalized groups in our society and how we may be serving or not serving them in pain care?
Right. Well, hugely, I think as a general principle, the services are most readily available and used by people in the middle to upper ranks of society, and people who live in marginalized communities. Our focus has been on indigenous communities, the LGBTQ population, and people with intellectual disabilities and other cognitive deficits of that type. The documentation in those communities and others like them, and the list could go on and on, is that pain is not recognized as important, and people do not intervene to provide services for them as promptly as they would for people like you and I, who are highly functional and adapted, know how to access the resources and how to attract the attention of other people. So we need to think specifically about those socially marginalized communities and what services should be delivered to them.
When you say they don't have, access versus adequate are two different topics. So someone can have challenges with access to pain care, and then someone could have challenges with receiving adequate pain care. Those are kind of two different topics, really.
Right.
Is it that they're more challenged to access pain management, or once they do access it, it's not adequate, or probably both at play here in some way?
Yeah, I think accessing is a skill, and it's something that you learn as a child. You recognize that you have personal needs, and I guess once you move into the adult years, you recognize that you've got to exercise these skills independently and assertively to get care. Another element would be effectively communicating the nature of your distress to other people. I know that my employment in pain clinics has reflected my professional expertise in assessing psychosocial factors, and so I would use interviews and brief psychometric devices, paper and pencil questionnaires, to access issues concerning stress, depression, um, uh, critical incidents in people's lives, their life history, those kinds of things, to establish where they would fit into the painful condition that has led the person to present themselves as a patient in a health clinic. Yeah.
Yeah, it's interesting when you say skills. I mean, really, I think that starts the point too. Someone has to have some kind of foundational health literacy or pain literacy to realize what's happening to themselves, and then how to negotiate the healthcare system, which can be really difficult in probably most parts of the world when it comes to pain management.
Yeah. Yes, indeed. I've read proposals, not to. I don't think anybody's ever really implemented them, but proposals that suggest children should be purposefully exposed to pain to teach them how to effectively communicate the nature of their distress to other people without these excessive reactions that I've talked about. Illustrates the point.
Yeah, well, I guess we've all experienced an injection when we're younger, right?
Oh,
And
indeed.
there's an opportunity there to express pain and to, process pain to a certain extent and what that means. But it is interesting to think, these are now people, some of the marginalized groups we're talking about millions of people, so to speak,
Right.
In every country that don't have access to adequate pain management. What does that really mean to, we're talking about social, right? What does that really mean for a society when you now have millions of people who cannot access adequate pain management?
Yes, indeed. I mean, that is a topic somewhat separate from how people react and cope with pain when it's presented to them. So I think that healthcare professionals can use strategies that minimize pain and distress in the course of injections, as you were mentioning a moment ago. And parents can be taught techniques for minimizing their own apparent distress, which has a palliating effect on the children. But I can't get my head around the complexities of delivering pain management services to the large number of people who are suffering from pain in communities and societies that don't think in these terms as you and I do.
Yeah, it's obviously a large problem because I feel like, there's been such awareness that's been raised around, okay, there are significant amounts of people with chronic pain, and an awareness that it's poorly treated, and an awareness that it's inappropriately treated with medication or surgeries for certain conditions, things like that. Yeah. And I think now kind of like we're starting to see, okay, now that we have all that, now we're starting to look at who's really on the very, very outside of the circle that we're just completely missing, right? They're really not, they're not receiving anything. They're not receiving medication. They're not receiving a primary care consult. They're not receiving psychology, physical therapy. They're receiving nothing almost.
Yeah.
And those are the the quiet lives of desperation that we have yet to really say, hey, there are human beings out there that need adequate care.
Yeah, I agree. I think the International Association for the Study of Pain, founded almost 50 years ago, has done a wonderful job of spreading the word concerning the importance of better understanding and pain management to the kinds of communities that you've talked about. I sat on the council of IASP, and I've been impressed by the breadth and diversity of professional and geographical representation on that organization. So I think IASP has done a wonderful job in that respect.
Yes, they definitely have. Ken, it's been great speaking with you. I will link to that paper so everyone can read it in the show notes. It's on social and marginalized groups of people who experience pain. I mentioned that in the introduction to today's episode. We can all access that on PubMed. You can read it. In the meantime, let everyone know how they can learn more about you and follow your work.
Great. It's been a pleasure to talk to you, Joe. And I would be happy to correspond with other people.
Great. So make sure to share this episode with your friends and family on Facebook, LinkedIn, Twitter, or where everyone is talking about chronic pain and the social aspect of the pain experience. I am most active on Instagram. You can reach out to me on Instagram. My handle is @drjoetatta.com. Connect with me there, and I'll be sure to connect back with you. I'm Dr. Joe Tatta, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.